Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 340B and U, what to know, what to watch for, what to do today. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenter, Sarah Bowman.
Thank you so much. Good morning. Welcome. So glad you're here with us today. As Jennifer mentioned, we're going to talk about a couple of important 340B topics today. First, let me just say that as attendees, we really value your feedback on webinar content. Today's agenda was really created based on feedback that we have received from past Healthcare Regulatory Roundup webinars. So please keep the feedback coming on what you're interested in seeing. We will absolutely continue to tailor our content accordingly. So today's webinar is intended to cover kind of two lanes. We're going to talk about 340B program, basics, a 340B 101, if you will, kind of an overview of the program, of the eligibility requirements and the compliance requirements that come with that, as well as some compliance, common compliance pitfalls. All of that content has been developed based on feedback, as I mentioned, from the webinar attendees in past. We can't really talk about 340B in today's healthcare environment without also sprinkling in what's going on, what are the recent happenings, the recent events, and what covered entities can do in terms of taking some action now. So we're going to try to cover both lanes in an hour. Please bear with me. I may have more content here in terms of the slides than we're able to cover, so I may move quickly through some of the slides, but I promise we'll try to capture all of it. If you are a seasoned 340B professional, hopefully this will be a good refresher for you, and you'll walk away with some nuggets based on recent events and things to do now. If you are new to the 340B program, the first portion of today's presentation is really aimed for you, for your benefit, again, based on feedback that we've received. Feel free to keep the questions coming through the Q&A pane, as Jennifer mentioned. I don't know that I'll be able to cover them during the presentation today, but we will follow up after the session. So with that, I will jump right in. Let's first talk about what 340B is. There are a lot of, it's become a bit of a political program these days. There's a lot of misinformation out there about what the program is and is not. So it was enacted in 1992. It's been around for quite some time now by President Bush. It requires drug manufacturers to provide covered outpatient drugs to eligible covered entities at significantly reduced prices. So typically somewhere between a 20 and 50% discount on drugs. The covered entities, or the providers that participate in the program, benefit from the difference between the drug's reduced cost and the unadjusted reimbursement that's received from payers, assuming that it is in fact unadjusted. Then covered entities are able to use these savings to provide additional community benefit programs to patients who need them, right? So the intent of the program, when it was created back in 1992, was to help covered entities stretch scarce federal resources as far as possible to reach as many eligible patients and provide more comprehensive services. So that's kind of, from a mission statement perspective, that is the intent of the program under HRSA as it stands. The program since 1992 has grown significantly, and that's part of why it has gotten the attention that it has in recent years. Pharmaceutical manufacturers aren't a huge fan, generally speaking, of the 340B program. They claim that covered entities, it's grown too large, it's expanded beyond the original intent of the program, that there needs to be more oversight, more reporting, more controls, if you will, on the program. And then you have the kind of provider camp that says, hang on a second, we wouldn't be able to do what we're doing today without 340B. We really need to protect it and sustain it and not change the way that it operates mechanically today. So in 2023, that's the most recent data that we have available from a reporting perspective, there were over $66 billion, billion with a B, in total 340B program purchases of covered outpatient drugs. There are over 14,000 covered entities that participate and over 800 manufacturers. So it is, again, quite a sizable program. My guess is that most of you all that are listening to this webinar today participate in the 340B program or are looking to begin participating in the program, and so trying to learn some more about it. So it's important to just kind of have those basics and understanding to start. This program is pretty near and dear to my heart. Prior to my consulting life, I worked for a health system that was part of a larger healthcare organization, and we had a number of 340B hospitals, and those dollars, the savings that came from 340B was very vital to the communities in which we served. So this is an area that I really enjoy working in and helping providers in. For that reason, I've seen firsthand the positive impact that it can have and how important it can be. So when we think about eligibility, everyone cannot participate in the 340B program. You have to meet certain criteria to be eligible to essentially enroll, sign up through HRSA to participate in the program. Essentially, there are kind of two categories of eligible entities. There are hospitals that are eligible, as you can see on the left side of this slide, as well as federal designees, federal grantees on the right. You'll notice a red box around disproportionate share hospital. That's calling out that covered entity type for two reasons. One, it is a very common covered entity type. A lot of our clients fit in the DISH hospital category, but certainly not all of them. We have the benefit of serving all types of 340B covered entities, including grantees, as well as other types of hospitals. But we're calling that out for today's presentation because a lot of what I'm going to talk about in terms of the scope of the program and compliance pitfalls and things like that are tailored to a hospital environment, are tailored to a disproportionate share hospital type. I'll try to call out areas where that is different as we go along. But unfortunately, the 340B basics content to expand beyond hospitals would certainly take more than the time that we have allotted today. So did want to call that out. As a reminder, for-profit healthcare providers are not eligible to participate in the 340B program, regardless of their DISH percentage. Freestanding private practice, privately practicing physician groups or clinics are also not eligible to participate. So even within these kind of eligibility buckets, if you will, that you see on this slide, there are additional criteria that have to also be met. I'm going to jump ahead one slide and hopefully not mess up. So from a hospital eligibility perspective, you'll note that there are different DISH percentages that are required based on the covered entity's most recently filed Medicare cost report to be eligible for either entering into the program or continuing program participation. So again, you see the red box around the DISH hospital type. DISH hospitals have to meet, they have to exceed 11.75% on their most recently filed Medicare cost report. That percentage is consistent for children's hospitals and cancer hospitals. You'll notice that critical access hospitals do not have a DISH threshold. RRCs and Soul Community hospitals have a lesser threshold to meet. They've got to be equal to or greater than 8% on their Medicare cost report. Covered entities can expand their participation locations beyond the four walls of the hospital by having child sites, what's called child sites. And so if you have an outpatient clinic or an outpatient department that's outside of the four walls of the hospital, you have to register those as child sites. They have to meet some additional compliance criteria to be able to participate, including the way that they are listed as reimbursable on your cost report. You'll notice a cost report theme through today's presentation. So they've got to be listed on the cost report with associated outpatient charges, but then you can register those locations and they can be eligible for 340B discounted drugs as well. I'm going to go back one slide. So in terms of timing, if you are a new covered entity that is going to be joining the 340B program, or if you are looking to make changes to your existing setup, your existing registration, the way that you're listed on the OPA database, there are registration windows, and it's important to be mindful of these. This speaks to not only kind of how to do that, but also the timing for those changes to go into effect. So the next registration window is coming up next month. It's July 1st through the 15th. Any changes made during that window would be effective October 1st. So if you are a covered entity that if you're a hospital, a healthcare system, and you don't currently participate in 340B today, but you plan to start participating, you've met all of the eligibility criteria from a cost report perspective, you can enroll during that July 1st through 5th window, but your effective date in which you can start purchasing drugs at that discounted 340B price would not start until October 1st. This table and timeline doesn't take into account the provider, the timing of your cost report filing. So for those covered entity types that have to show that specific dish percentage, HRSA is going to expect to see that on their most recently filed report. So that also has to be factored in when we think about joining for overall program participation. If you're making a revision, such as a child site, it's a little different, or contract pharmacy arrangements, it's a little different there. But those initial registrations have to take that into account as well. This is just a quick snapshot of what the OPA database looks like and how covered entities can be registered. All of the information really about your 340B program is accessible at this link. If you haven't looked out there lately and you participate in the program, it's a great idea to make this part of your kind of regular annual ongoing auditing and monitoring efforts. Just want to make sure that everything that's listed on HRSA's OPA database is correct, is current. We have seen findings for things as small as, an incorrect address. Maybe the database lists avenue instead of street, for example. I mean, it can be very minor and very particular, but that is the level of precision that HRSA is expecting to see. So definitely check to make sure the way that you are registered, the way that your program is set up. There are other pieces about the program that will be listed there as well. So you will see parent and child site information. You will see whether or not an organization carves in or carves out for Medicaid billing purposes, and information about contract pharmacy relationships, as well as your authorizing official. So when we think about participation in the program and continuing to participate in the program, every covered entity has an individual within their organization that's named as the authorizing official, the AO, and that person physically has to do the attestation process to stay in the program every year. That attestation process is very important. That's part of recertification. And when you are attesting, you are attesting to all of these things. So you're attesting that what's out on the OPA is correct, that you're going to comply with all the program and eligibility requirements, that you're maintaining auditable records, that you have systems in place to ensure ongoing compliance, that all of your contract pharmacy arrangements are in compliance, and that you're going to notify OPA regarding any significant changes to your program, and that you understand that you may be liable in the event of a breach if it's found or determined that you have purchased 340B drugs that you shouldn't have, or 340B drugs were inadvertently diverted to patients that were not eligible, which we'll talk about more here in just a minute. The covered entity is responsible for maintaining program compliance. So while covered entities can and oftentimes do outsource certain components of their program, perhaps to TPAs or to split billing vendors or to consulting firms like PYA, even to help with compliance and to help with perhaps policies and procedures or some of the auditing and monitoring efforts. The responsibility at the end of the day for program compliance cannot be delegated or outsourced. It remains with the covered entity. And so I just call that out because sometimes we see organizations that have placed perhaps too much stake or too much trust in some of their vendor relationships to be managing and maintaining compliance, and sometimes that can be detrimental for their program. So the great thing about doing this webinar and having a webinar format, thanks to technology, is that you all can see me. I'm guessing that we've got folks probably attending from all different areas, all different states and locations across the country. I'm physically based in Knoxville, Tennessee. That's where I am today. So this webinar format allows all of us to come together without, having to travel or anything like that. But the downside for me as the presenter is that I don't get to see your faces and I don't get to see your body language as we go through these slides. But I can tell you, based on past experience, that I'm guessing that this slide and what we're going to talk about on this slide may generate some eye rolling, and that's okay if you're rolling your eyes as we start to talk about policies and procedures, because I don't know anybody that is super excited to talk about policies and procedures, to draft them, to review them, to update them. I don't know anybody that's thrilled about that, but it is a really important part of your 340B program infrastructure and of your program's compliance. So you want to make sure within your policies and procedures, and it's okay if you rolled your eyes, that you want to make sure that you are addressing the patient definition, that it is well documented and well defined, that you have detailed policies and procedures that reflect current state as it stands today. So maybe what you did pre-COVID is different than how your program looks today. Maybe you updated it during the COVID public health emergency timeframe, but again, operations hopefully have gone back to a normal state or a new normal state. And so making sure that whatever is documented in the event of an audit, we as PYA are going to expect that your policies and procedures reflect your current process. We will ask questions of the people involved with 340B to test that. That is also what HRSA will do in the event of an audit. We have seen firsthand the Bazell Group really dig in and really ask the compliance officers and the folks involved with internal audit and the pharmacy director, okay, this is what your policy and procedure says. Tell us how you're doing that. Show us the support for these activities. Show us how this is actually being operationalized. So what you have written there is very, very important. That is kind of your starting point of your program. Part of that policy and procedure infrastructure should include how you are retaining the records that you need to support your program. Again, in the event of an audit or in the event you find something that has gone awry, which we will talk about ways that can happen, and we have seen that happen with our clients, that you're maintaining those records in a format where they are readily accessible and available as needed, and that you are maintaining appropriate oversight of your processes internally. You're doing those checks and balances and auditing and monitoring. 340B inventory models. I told you I was going to go quickly through the basics, so that's exactly what we're going to do. Generally speaking, most covered entities have a replenishment model when it comes to 340B. There are some caveats to that. We do see a separate physical inventory model, sometimes with our smaller clinic clients, grantees. Sometimes we will even see that in areas where 340B eligibility is almost guaranteed. So if you have an area, perhaps an outpatient area that only treats 340B eligible outpatients, perhaps your organization carves in Medicaid, so you're including Medicaid in your program, you're only seeing outpatients in that area. So it's kind of sometimes it's referred to as like a clean site, where you know that every patient that you're seeing in that location is going to be eligible for 340B. Sometimes then we will see a separate physical inventory model. Some of our grantee clients will have, within their drug closet or their room, they will have a shelf that is everything on this shelf was purchased on 340B, everything on the shelves below it was not. So they'll have some physical distinctions there, but generally speaking, the vast majority of covered entities have a replenishment model where inventory is separated virtually. So you've got a split billing software vendor tracking system methodology that is helping to determine from that inventory that started out as a neutral inventory environment, how many dispensations that you have accumulated on 340B and how many are not 340B eligible. And that helps both track savings, it tracks your dispensation activity. It also informs your future purchasing, your inventory amounts and your future purchasing decisions as well. So the oversight of something like that is very important. And so HRSA expects that covered entities are going to have a manner to make sure that ineligible patients, so inpatients or patients that aren't patients of the covered entity or prescribers that are not considered eligible prescribers, are not dispensing drugs, or those drugs that they are involved with are not being classified as 340B eligible. So in that virtual environment, the eligibility of every drug has got to be tracked in some way. And that's very important as covered entities, that you all are doing some sort of testing of that. So one of the things that we look for, and that we understand that HRSA is going to look for, is if you are a disproportionate share hospital, that is the covered entity type that you fall under for 340B registration and eligibility purposes, then you are subject to the GPO prohibition. So that essentially means that you're expected to have most likely 3 purchasing accounts. So you're going to be purchasing drugs on either a 340B account, a GPO account, or what's called a wholesale acquisition cost, or WAC account. That WAC account is going to be that highest sort of sticker price that no one really wants to pay if we can figure out another way, because it's going to be the most expensive. That 340B account is a great account, but of course we can only use that for covered outpatient drugs for eligible outpatients. That is that 20 to 50, 25 to 50% savings that we talked about earlier. And then in the middle, you've got your GPO account, which can, through collective negotiations, offer some reduced pricing, but that GPO account is only applicable for inpatient drugs for organizations that are subject to that GPO prohibition. Again, the purchases have to be tracked from all of these various accounts. And this slide probably breaks a lot of PowerPoint rules. So if you're not at your computer, you can reference this slide later. I will attempt to describe it quickly. But on slide 16, this slide gives you a visual of how that split billing software function can work. So when it's called split billing for a reason. So it really looks at the package sizes associated with drugs, the eligible accumulations, so what the organization has dispensed under each of the various types of accounts, and then which accounts have enough accumulations to buy more. And so this system is deciding what drugs need to be purchased on a GPO account versus what drugs need to be purchased on either 340B or perhaps on a WAC account. I told you I was going to go quickly. So when we think about diversion in pharmacy and drugs in a health system environment, or just a healthcare environment, period, it typically means something a little different than diversion as it relates to 340B. So diversion for 340B purposes is when an individual who's not an eligible outpatient is dispensed a drug, a 340B drug, or the drug is dispensed in an area of the facility that is not eligible. So basically those eligibility requirements are not being fully met. And so HRSA has given us some guidance. 340B, if you haven't heard, it's known as a somewhat gray area, somewhat gray program. We have great information, but we don't always have as finite or specific information as we would like to have when it comes to 340B program compliance. So HRSA's current guidance, which is rather old, I might add, on patient eligibility is that the covered entity must have an established relationship with the individual. They must maintain records of the individual's health care, and the individual must receive healthcare services from a provider who is either employed by the covered entity or has a contractual or other arrangement with that provider and between the provider and the covered entity, such that the responsibility for the care remains with the covered entity. And so that second bullet there, when we talk about provider, that's really getting at prescriber. The prescriber that ordered the drug or wrote the script for that individual, essentially for that patient. The individual must also receive healthcare services that are consistent with essentially the scope of the grant funding, the services that have been provided. That is a grantee requirement that does not apply to hospitals. And then last but not least, an individual is not considered a patient of the covered entity if the only healthcare service that they're getting is the dispensing of a drug for subsequent self-administration or administration in the home setting. So this is the guidance that we kind of have to start with. But then there are other patient eligibility factors that we also need to take into account. And so this slide attempts to cover all of them on one slide, which again, I'm breaking some PowerPoint rules here, but hopefully these slides are a helpful reference. So we also take into account prescriber eligibility. So is this a prescriber that is on the covered entity's eligible prescriber listing, the location in which the prescription originated, and this can become very tricky for covered entities that have a lot of community physicians on their medical staff. So they may have privileges with the covered entity, but they may also have a private practice elsewhere in the community. And so making sure that those scripts that originate from that private practice location aren't inadvertently qualifying for 340B. Patient status. Obviously, 340B is an outpatient drug discount program. When a patient's status has become inpatient, they are no longer eligible for 340B drugs. And it can be, very much in the minutia of the details. Patient presents to the ER, they're admitted for observation tomorrow. By Friday, they have, their care has their condition has deteriorated, and now they need to be admitted for inpatient, making sure that after that admission to inpatient status is written, that the patient's not getting any 340B drugs after that point. So that's where some of the technology comes into play with your split billing software company and the way that those parameters are set up. I already talked about GPO prohibition. We'll talk more about orphan drugs in a moment, a bit later, but for covered entities that are subject to the orphan drug exclusion, that is another thing to be mindful of. And then last but not least, payer status. And so as part of enrolling and registering in the 340B program, covered entities have to elect whether to carve in or carve out Medicaid. And so if they carve in, that means that they include Medicaid patients as part of their 340B program. And there are some responsibilities for making sure that their information is properly outlined in the Medicaid exclusion file, which we'll also talk about in a minute. So all of these factors have to be taken into account to make sure that only eligible patients are qualifying for 340B. So this is how it becomes a bit complex when you think about the total volume of patients receiving care across your organization and the various sites of care and providers and all of that. So an area that has come under lots of scrutiny in recent years are contract pharmacy relationships. So covered entities are allowed to establish relationships with contract pharmacies. So in addition to the savings that can be generated from a hospital's mixed use, what we call mixed use in-house kind of hospital pharmacy environment. Mixed use meaning it's treating, prescribing or providing drugs for both inpatients and outpatients out of that same pharmacy location. There's also the ability for covered entities to establish contract pharmacy relationships. And when we think about contract pharmacies, it's the big names that you are familiar with, the Walmart, the Rite Aid, the Walgreens, CVS, as well as oftentimes covered entities will leverage relationships with maybe some local pharmacies if they see that a lot of their patients are using local pharmacies that are near the hospital or in their community, near their place of work or their home. So those contract pharmacy relationships allow covered entities to expand the scope of their program, potentially increasing access for patients, helping to add to their savings. So it is generally thought of as a positive thing. It has definitely been challenged in recent years by pharmaceutical manufacturers, but the expanded kind of benefits don't come without some risk. So there is expanded compliance risk in monitoring those relationships and making sure that the Walgreens and the Rite Aids of the world are correctly identifying what patients are patients of the covered entity, what scripts are from eligible prescribers, and that those should be filled and part of an organization's 340B program. This is a contract pharmacy process map. I'm not going to go through this in great detail, but this really outlines kind of the flow of both information and the drugs themselves. So if you are a covered entity and you have a contract pharmacy relationship, it is a bill to ship to arrangement. So that means that the drugs are billed to the covered entity for replenishment and shipped physically to the Rite Aids, the Walgreens, the whomever you've got those contract pharmacy relationships with, for them to continue to fill those on your behalf. So those contract pharmacies are generally part of that split billing software kind of brain decision making, what should be qualifying and how. It's very important to make sure that the way that those eligibility criteria are set up are in a manner that is supportive of the 340B program's compliance for the covered entity, that things are not qualifying that should not be. The next two slides talk about the contract pharmacy arrangement contractual requirements. So HRSA expects that if you're going to have a contract pharmacy relationship, that you have listed that appropriately on the OPA as part of your covered entity registration, and that these 12 essential compliance elements have been met in your agreement. I'm not going to go through all of them. This is something that when we do mock audits, we look for. We ask for copies of all of your contract pharmacy agreements. If you are hearing me say this right now and you're thinking to yourself, gosh, I have not seen some of our contract pharmacy agreements since 2012, now would be a great time to try to locate those, dust them off, make sure that the copy that you have is fully executed, make sure that the copy that you have lists all of the currently active in-use locations. So if you have a contract pharmacy arrangement with Walgreens, and we all know that there is a Walgreens, it seems like on every block, maybe there are 10 Walgreens locations listed in that agreement, but you haven't used 5 of them in the past 5 years, making sure that those get taken off of your agreement, and also that those current locations, including their correct address for each location, are properly listed on the OPA database, because that check and balance is something that the Bazell Group is going to look for when they do, when and if you are audited. The other thing that I'll call out as it relates to contract pharmacy agreements is number 9 on this list, and that says that the contract pharmacy may not dispense 340B drugs to Medicaid patients unless the covered entity, the contract pharmacy, and the state Medicaid agency have established a specific arrangement. Those arrangements are generally pretty rare, and it can be difficult to establish those. So generally speaking, when we're looking at dispensation data, we're expecting not to see any Medicaid activity within your contract pharmacy reports. So within your dispensation reports for the Walgreens, the Rite Aid, the Walmart, whomever. Oftentimes, but not always, your big box retail pharmacies do a somewhat better job of keeping track of your BIN and PCN information for state Medicaid plans. It can be tricky to capture them all, and that's how we sometimes see, especially if you're in a state with a lot of Medicaid managed plans, that some of those can kind of inadvertently slip through the cracks and qualify as eligible when they should not. So that's something definitely to watch for as you're reviewing your dispensation reports. We've also noticed that your mom and pop, more local kind of regional pharmacies can sometimes struggle with this. So it's important that as part of your internal compliance auditing and monitoring that you are including that as a check, testing for it when you're looking at dispensation data, and then following up with those pharmacies if that's something that they don't have all of the correct information loaded into their systems. It can be a very easy fix, but it can be kind of messy and costly on the back end to remediate if it's not caught quickly. So we've talked about kind of 340B basics, 340B overview of the program. I went pretty fast. Hopefully that was helpful. There's also a recording available if you need it. Now we're going to shift gears a little bit and talk about what to watch for and how to avoid common compliance pitfalls that we oftentimes see. So first things first, we talked about determining prescription eligibility, and I showed you that slide that had the 6 boxes on it and the very, very small text, which I apologize for it being so small, on the different criteria that you've got to think about and look for when determining prescription eligibility. And when I say you, I really mean within your software, within your TPA arrangement or your split billing software. Most covered entities are using some type of software to help them track and identify what are those eligible accumulations through some set of rules or parameters. But it's important to test that pretty regularly. For most covered entities, we recommend testing on a monthly basis, at least some small sample of patients. You can also do some testing just at the dispensation report level. So if you pull your dispensation report for the last month or the last 3 months, look for provider names that you may not recognize. If you have contract pharmacy relationships, again, I mentioned earlier, checking those dispensation records, look for drugs that may not be appropriate for humans, look for dosages that look off, look for drugs that look off, and look for non-human names. You may be laughing at this, but we have seen this with a number of clients where they have contract pharmacy relationships with pharmacies in the community. And, you know, Sarah Bowman is a patient of the hospital, and Sarah Bowman's children are patients of the hospital, and we probably have all received 340B drugs and not known it, if I had to guess. If you have sought out care as an outpatient in a not-for-profit health system environment, you probably have been touched by 340B, even though you might not fully be aware. But we've also seen instances where kind of same patient last name, maybe a dummy date of birth, but an interesting first name like Fluffy, Fluffy Bowman, that might be a cat or dog. Those non-human names or names that are typically not assigned to humans have popped up, and upon further review have realized that that's a script from a vet in the community that was filled at Target or Walmart or Walgreens. So that's kind of a real world example, a little funny, but that we have actually seen happen. So that's an easy thing that you can visually kind of check for. Bigger picture, if you step back and look at your program, it's important to watch for large swings in volume. So if your historical dispensation volume has been X and suddenly that shifts 15% up or down, investigate that. Over what period of time are you seeing that shift? Does that coincide with any other kind of explanation that you can have within your organization as to what may have happened? So perhaps you did open a new wing of the facility, or you've added a large physician group as part of your organization. There can be reasons that you might see a significant shift. Maybe you added some contract pharmacy relationships. Those deals, those agreements finally got inked, and you're off to the races there. Those are good reasons, supportable reasons why you might see a volume shift. But absent something like that, seeing a large decline or a large increase generally warrants further review and investigation to figure out what is happening that's causing these shifts. Typically, where we have worked with clients that have had those experiences, it generally, not always, but generally comes back to some sort of an IT change. It was an EMR go live period. It was an upgrade in a system. It was a change in a system, a patch update, any of these things, because this is so heavily reliant upon the split billing software, as I mentioned, can cause those swings to occur. Duplicate discounts. So duplicate discounts can occur when a manufacturer provides a 340B discount at the time of purchase and then later pays a Medicaid rebate on the same drug. And that is why it's important for covered entities to tell HRSA, we're going to carve in or we're going to carve out as part of our 340B program. So it's important that the Medicaid exclusion file, if you are carving in, that your Medicaid exclusion file be current, because that is the notification sort of channel for your state Medicaid agencies to tell them, hey, we as the hospital are going to be getting a discount on these drugs already, so you guys don't need to also go ask for rebates on those same drug claims. Typically what we have seen most recently in terms of issues from a duplicate discount perspective is, it can be a clerical error, it can be a typo in the provider number on the Medicaid exclusion file. It can be that you've listed 3 of the 4 and you forgot the 4th provider number in the Medicaid exclusion file. There are varying levels of sophistication across state Medicaid agencies as to whether or not they're catching those and seeking those rebates or not. So if you identify that you've got an issue or a potential issue as it relates to your Medicaid exclusion file and you carve in, your first order of business is to get in contact with your state Medicaid agency to determine if in fact there were instances of duplicate discounts. So that is important. And then don't forget that there are typically some state-specific billing requirements when it comes to 340B acquired drugs that are Medicaid, 340B acquired drugs that are going to Medicaid patients. So making sure that you have your bases covered there as well. And then this sounds very obvious, but we have also had clients that had made a decision to carve in or carve out. At some point, their processes had changed and their operations had changed, but the way that they had their declaration, if you will, on the OPA database had not followed suit. And so make sure that what you're, again, actually doing in practice and process in your day-to-day operations is aligned with kind of the central processor of your 340B program, which is the way that you are listed on the OPA database. This slide talks about the orphan drug exclusion a little bit further. Essentially, as of now, covered entities that are subject to the orphan drug exclusion, so sole community hospitals, cancer, RRC, and critical access, are not able to purchase orphan drugs at 340B pricing. So that's another check. If that exclusion applies to your organization, that is something that you can easily check for. You can pull the orphan drug listing and you can cross-check, using an Excel spreadsheet, you can cross-check periodically to make sure that you're not inadvertently counting anything. Typically, your split billing software vendors are very familiar. This is not a new requirement. So typically that is something that they have logic built in their systems to catch as well. But we have seen issues with that from time to time. And so essentially, there was some back and forth about whether or not the drug was being used for an orphan drug indication. Since 2015, essentially that was invalidated. And so covered entities are prohibited from purchasing any orphan drugs on 340B, regardless of the indication for the medication. While it's not listed on this slide, there are similar checks that are needed if you are a DISH hospital and you participate in the 340B program and you're subject to that GPO prohibition that we talked about earlier. So making sure that when you're doing your purchasing, that you're not getting covered outpatient drugs on your GPO account from an inventory management perspective. Last but not least, you've heard me say split billing software a lot. But this is because it is such a decision maker for how drugs are qualified within your program, it warrants its own slide, and it warrants its own maintenance activities and checks and balances, if you will. So anytime you're going to be doing any kind of a system update or an upgrade, maintenance activities, those can have, an inadvertent impact on your functionality of your system. So it's important to kind of test before and after, if you can, if you know about those changes and know that they're coming. We know a lot of organizations that are in the process of transitioning or have recently transitioned EMRs. That EMR change and or a change in your patient financial system or your registration system, if they're not all linked, if any of those pieces change, it can have ramifications for your 340B program, mainly because of the interplay between how the admissions, discharge, and transfer, or ADT, information is fed from the point of registration, and then any status changes that might happen with that patient. You may remember my earlier example of, a patient comes in through the ED, they're admitted for observation, their condition worsens, they become an inpatient, making sure the timeliness of that information getting pushed all the way through to the split billing software so that the split biller knows, okay, once Sarah Bowman is an inpatient, she's no longer eligible for these drugs on 340B. The timing really does matter, and we see sometimes when there are batch feeds or batch processes that are taking place versus like a real-time HL7 feed of information, sometimes that can be problematic for covered entities as well. So just know that if you do not have a real-time feed, you may want to spend some additional time and attention looking at your dispensation data to make sure that you don't have inpatients that have inadvertently qualified. Other things that we have seen, if you are, if either because of some of these changes or some other reason, if you're making changes to your CDM. So sometimes CDM updates are made in conjunction with a change to EMR. We know that Epic has its own kind of manner in which it handles NDCs and package quantities and things. We have seen that create compliance issues for clients post go live because of a difference in how a prior EMR handled the package quantities and sizes and how their new system did. So look for those changes again. And that's something where if you're watching just purely based on volume, you're likely to see it. And then you'd have to kind of dig a little deeper to figure out kind of what's the root cause. Don't forget to look for patient type codes. So whatever kind of mnemonic or abbreviation that you're using for patient type, inpatient, OBS, ED, outpatient ancillary, et cetera. And then the location code. So the way that the different locations within your organization are classified or characterized, we've seen that cause problems post-system transition most often. And then last but not least, we haven't touched on this as much, but making sure that you're making routine updates to your organization's provider listing. So looking at all of your eligible prescribers, making sure that you're getting updates from medical staff, you're getting updates from your provider credentialing team, if new providers need to be added or if providers are no longer part of the organization and need to be taken off. So remember that relationship for prescribers to be eligible. It can be an employment relationship, it can be some other type of contractual relationship like a PSA agreement, or it can just simply be that they are a privately practicing physician that has medical staff privileges. So any of those can be considered eligible under 340B. It is important that you define that within your organization's policies and procedures as to how you classify an eligible prescriber. So enough scary stories, enough 340B program basics. Let's talk a little bit about what is happening now and what you as covered entities can do when you're thinking about maintaining a strong program and a strong compliance in this environment. So I want to give some updates first. There's a lot happening from a pharmaceutical manufacturer standpoint. Many of you are probably aware there have been outright denials for some time now, I'd say a couple of years, on 340B pricing for items shipped to contract pharmacies. So we've seen pharmaceutical companies say, nope, we're not going to give you 340B discounts on those bill to ship to arrangements anymore. We have seen other restrictions tied to contract pharmacy based on dispensation data that has become required reporting using 340B ESP. And then we've seen other instances where there are restrictions, but some exceptions, which makes it tricky for providers, covered entity providers. So they might say, we're going to limit your access to 340B pricing to only a single contract pharmacy, and only a single contract pharmacy if you don't, as a health system, have an in-house retail pharmacy already. So we've seen some restrictions like that coming through. So some of this has been in play, as I mentioned, for a period of time now. We have seen other, I'll say the more breaking headlines relate to kind of a revamp of the way the drug discounts work. Pharmaceutical manufacturers, a number of pharmaceutical manufacturers are pushing for a rebate model. So Eli Lilly, Bristol Myers Squibb, Sanofi, and Novartis are all in litigation right now. They are pushing, and there may be some others too, that are in litigation right now, pushing to implement a rebate model for either certain drugs or all drugs, which would require covered entities to foot the bill for the drug up front, pay full freight for those medications, and then later on the back end, through whatever series of administrative hoops, prove that those drugs were in fact eligible, that they were eligible to be participating in the program, that those went to eligible patients based on all of the criteria that we have talked about today, and then get a rebate through whatever methodology and mechanism the pharmaceutical manufacturers have established. It's not surprising that covered entities are generally not thrilled with this. The hospital industry as a whole is not thrilled with this. Last year, we saw this initial push. I think Johnson & Johnson was the first to put their toe in the water on a rebate model. They came out pretty strong, and HRSA repeatedly had to tell them, you can't do this, you need to back down. And if you don't, they actually eventually wrote in a letter, the former HHS Secretary Becerra wrote in a letter to Johnson & Johnson that, if they proceeded with this rebate model, that they would pull the Johnson & Johnson's pharmaceutical pricing agreement, and also would go as far as to imposing civil monetary penalties. So not surprising, Johnson & Johnson stepped back and said, okay, we're not going to do this. They did file lawsuits and are fighting that decision. And so it remains to be seen right now what's going to happen now that we've got other drug manufacturers that are trying to get on this rebate model plan as well. And so we have the four pharmaceutical manufacturers that I mentioned. HHS has since filed for summary judgment. I believe that happened last month in May. They have filed for summary judgment in their favor against the pharmaceutical companies. And so right now, we're not sure where this is going to land, but we do know and can kind of predict that if the rebate models are permitted in a future state, it's expected to be financially damaging for covered entities. There are some covered entities that probably couldn't do this today, just financially, knowing what the 340B program means to them from a pure dollars perspective. So time will tell kind of what is going to happen next with that. The other thing that's happening, there's so much happening in 340B on both a state and federal level. So we've got some states that have proposed bills out, and many states have now passed legislation that aims to protect covered entities and their right to get 340B discounted drugs. So kind of firing back, if you will, at some of the manufacturer restrictions for getting 340B drug pricing at contract pharmacy locations, for example, that I mentioned. So a lot of these bills that are aimed at ensuring that can't happen, that the pharmaceutical companies can't restrict that access. That's a positive step for providers. However, there are a lot of other things that are happening that are possibly less positive for providers in the long run, or it's unclear right now kind of what impact it's going to have. And so you may recall back in 2018, we saw Medicare reimbursement be reduced for separately covered payable outpatient drugs. And so previously reimbursement had been ASP plus 6%. That shifted to ASP less 22.5%, so almost a 30% reduction, a haircut in reimbursement for drugs that were acquired under 340B. This went on from 2018 through 2022. There were a whole bunch of lawsuits and legal challenge ensued on this. Eventually, the reduction was later reversed. It was reversed back to ASP plus 6, which is where it is today. And Medicare actually repaid those reduced amounts to providers in lump sum payments. And what's interesting about that is that the ultimate U.S. District Court ruling on that was that the cuts were unlawful because Medicare failed to do the appropriate survey of drug pricing that they should have done prior to implementing those cuts. So fast forward to present day, in April, we had an executive order that was signed by President Trump, which requires essentially that survey. It requires an analysis of drug pricing. So it seems that this is kind of going back to that survey process. Many expect reimbursement changes will follow in the future for 340B acquired drugs. We recently were asked about tariffs. There is this, tariffs are coming, tariffs are happening. There is a potential to have an impact related to drug prices in this country as a result. If there is a push to bring all of that manufacturing into the United States, what is that going to mean for drug pricing? In theory, if drug prices go up, the 340B savings associated with those drugs could also increase. But that assumes that the reimbursement stays somewhat consistent with what it is today, and that the reimbursement doesn't have some other sort of reduction, which we expect that it might. And so if drug prices go up and the reimbursement goes down, that's something certainly for providers to watch for. And then last but not least, the elephant in the room, if you will, the most recent announcement that HHS plans to eliminate HRSA and transfer its responsibilities, including the oversight of the 340B program, to CMS. And so this was outlined in the Health and Human Services fiscal 2026 budget request. We expect that this shift will bring stricter oversight of the program, given CMS's broader regulatory authority as compared to HRSA. So now is a really great time to kind of do a little bit of, it's not really spring cleaning, it's probably summer. I don't know if summer cleaning is a thing, but it's a great time to kind of kick the tires on your program compliance. Dust off that policy and procedure manual. If you have contract pharmacy arrangements, look at those agreements, locate them, make sure that they're signed, make sure that they're current, make sure that they address the 12 essential elements that are referenced in this slide deck. And last but not least, make sure that the locations that are referenced in those agreements match what you have on OPACE. And if not, make those adjustments as soon as you can. So really take this time to evaluate and strengthen your compliance efforts, prepare for what might be some rocky compliance road ahead. Now is not the time to be quiet about 340B. So if you've been sort of resting and hanging out to see what might happen, now is the time to pursue advocacy. So pursue local and state advocacy efforts. Make sure that your lawmakers in your area know about the program, that they understand from you as a provider what this program means and the benefit that it allows you to provide to your community, to the patients that otherwise might not have access to care or may not be able to get their chemotherapy or their mammograms or whatever you're doing. So develop your organization's impact statement. Your marketing and PR team can help with this if you don't already have it, but get the word out. Get it out on your website, get it out with your, make sure your employees are aware, make sure your physicians are aware. Because of 340B, we are able to do these things. Or without 340B, we wouldn't be able to have these programs or do these, have these services for patients in our community. I think that I'm right at time. Hopefully that was helpful. We've got a lot of great content coming up later this month. So starting, I think next week, we have our PYA Summer Symposium. There are 4 total sessions over 2 days. These are complimentary. CPE credits will be offered. So if that's something that you need, please feel free and do join us for those. Register on our website. Our next Healthcare Regulatory Roundup session will come on June 25th, where we will dig more into Washington updates, which should be very helpful and great. If you haven't already, feel free to sign up for our free DC update newsletter. It is a weekly newsletter where we attempt to kind of summarize policy changes into actionable insights that are helpful to you. That's all that I have for today. I'll turn it back over to Jennifer. Thanks so much for joining us.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.